Hi everyone, and thank you for your interest in this presentation. My name is Amani Hamad. I'm a postdoctoral fellow at the Center for Healthcare Innovation at the University of Manitoba, and I'll present our research titled The Association of Sibling Fracture History with Major Osteoporotic Fractures in Individuals from a Population-Based Cohort. And I'll start with a brief background. Major osteoporotic fractures, or MOF, are fractures occurring in hip, forearm, humerus, or spine. There are over 150 million people at high risk of MOF worldwide, and it is projected that this number will double in 2040. MOF is associated with long-term adverse outcomes on function, mental health, and quality of life. For example, 30% of individuals entered long-term care facilities after hip fracture, and 20% died within 1 year. Therefore, it is essential to identify people who are at risk of MOF to inform intervention strategies aimed to prevent fractures and reduce their impact on both patients and the healthcare system. To the right of the slide, you can see a snapshot of the Fracture Risk Assessment Tool, or FRAX, which estimates the 10-year fracture probability based on demographic and clinical risk factors. It includes parental hip fracture history, which is a known risk factor of fracture. But unlike parental history, data on sibling fracture history and its association with fracture risk are limited, conflicting, and largely dependent on self-reported history. Therefore, we aimed in this research to determine the association between objectively ascertained, which means clinically diagnosed, sibling fracture history with MOF risk. This was a retrospective population-based cohort study in the province of Manitoba, Canada, using administrative databases from the Manitoba Population Research Data Repository. The repository includes all encounters with the universal and publicly funded health system, such as hospitalizations, outpatient physician visits, and drug dispensations. It also allows the linkage of family members through unique scrambled identification numbers. We used 5 databases from the repository. The Manitoba Health Insurance Registry includes all individuals registered for health coverage in Manitoba since 1970 and provides their demographics, family composition, and date of birth. This was used to create the study cohort, establish family linkages, and identify their demographics. The hospital abstracts and the medical services databases were both used to identify the exposure, which was sibling MOF history, the outcome, which was incident MOF in the cohort members, and also the covariates. The Drug Program Information Network, which captures outpatient drug dispensations, was used to identify some of the covariates. Canada Census was used to create an area-based socioeconomic measure. The cohort included all individuals 40 years of age and older, identified in the registry between 1997 and 2015. The index date was April 1st, 1997, or the date when an individual turned 40, whichever occurred later. Cohort members were linked to their siblings using unique family identification numbers, which are usually assigned to children and their parents living in the same household. We included both full and half siblings. Individuals who were not linked to at least one sibling were excluded from the cohort. The primary exposure was a history of sibling MOF diagnosis occurring at age 40 years or older. It was time-varying and accumulated annually. The outcome was incident MOF diagnosis in the cohort members. MOF for both the siblings and cohort members were identified from hospitalizations and outpatient physician visits using established case definitions. The covariates included known fracture risk factors, for example, age group, sex, an area-based income quintile measure, rheumatoid arthritis diagnosis, COPD diagnosis, which was used as a proxy for smoking, prior MOF diagnosis, alcohol or substance abuse diagnosis, which was used as a proxy for high alcohol intake, prolonged oral glucocorticoid use, and the use of osteoporosis medications. We used multivariable Cox proportional hazard regression models. The main analyses examined MOF risk in association with sibling MOF history in the overall cohort and also stratified by sibling and individual sex. we conducted several additional analyses, for example, by examining the association with minor sibling fractures and with the number of sibling fractures, by examining different fracture sites in the siblings and the cohort members, and by restricting the cohort to those with full siblings. Moving on to the results, our cohort included just about 218,000 individuals who were followed up for a median of 11 years. During follow-up, we identified 5,235 incident MOF cases, which included 234 hip fractures. This table summarizes baseline characteristics stratified by the outcome, which is incident MOF. Cohort members who had an incident MOF were more likely to be female, slightly older, and to be in the lowest income quintile. They were also more likely to have a prior MOF, to have had used glucocorticoids, had a diagnosis of rheumatoid arthritis, COPD, or alcohol abuse. The first plots here show the hazard ratios and confidence intervals in the main and secondary analyses. In the plot to the left, you can see that we found that sibling MOF history was associated with MOF risk with a hazard ratio of 1.67. The risk was highest with female siblings and with sibling history of forearm fracture. In the plot to the right, looking at the site of incident MOF, the risk was similar regardless of fracture site, except for hip fracture, which was not found to be associated with sibling fracture history. With that being said, hip fracture events were rare in our cohort, so results of the analyses based on hip fracture should be interpreted with caution. The risk of MOF did not change after restricting the cohort to full siblings, with a hazard ratio of 1.64. The number of sibling fractures was associated with MOF risk with a hazard ratio of 1.18 per fracture. We also observed a weaker association between minor sibling fracture and MOF risk with a hazard ratio of 1.18. In the subgroup analysis based on sibling and individual sex, we found that MOF risk was highest among sisters with a hazard ratio of 2.03. This research has several strengths. We had a large and representative cohort with a population-level linkage. We also had a relatively long follow-up period. We used objectively ascertained measures with established case definitions, which reduces the risk of recall bias and other sources of misclassification. And we included numerous fracture risk factors or their proxies. But we also note some limitations. Hip fracture events were rare in this relatively young cohort, which could have resulted in overfitting in modeling hip fracture risk. Additionally, the exclusion of individuals due to a lack of sibling linkage could be partially attributed to missing sibling information in the data source. Finally, clinical and lifestyle risk factors such as BMD, body mass index, exercise, the use of vitamin D, for example, are not recorded in the administrative databases. Therefore, unmeasured confounding is a potential limitation. In conclusion, we found that sibling fracture history is associated with increased MOF risk. Therefore, sibling fracture history provides a candidate risk factor and should be considered for improving fracture risk assessment. We recommend future studies to examine the influence of sibling fracture history in improving fracture risk assessment and to evaluate whether this observed risk is independent of parental history. We also recommend studies to identify the biological mechanisms responsible for the familial transfer of MOF risk. I would like to acknowledge my co-authors, the Canadian Institute for Health Research for funding this research, the data custodian, MCHP, and the data provider, Manitoba Health, and finally, the University of Manitoba. Here's my email. Please contact me if you have any questions or comments, or feel free to post them in the conference Q&A section. Thank you all for your attention.